So this is part 2 of cardiovascular disorders. This is a really good picture because today we're going to talk about, or in this part 2, we're going to talk about coronary artery disease. And this is really a good picture or a good graph of where those coronary arteries are. So when blood flow is blocked to one of these arteries, causing an MI, we can kind of have a good picture of where that blockage is or where it lies in those arteries around the heart. So keep this picture in mind. I'm going to show you another one in a few slides as well. So we are going to refer back to this diagram. In part 1 of these cardiovascular disorders, we talked about atherosclerosis, how that is an abnormal disease process as one ages, but also about arterial sclerosis, which is a normal age-related change to the vessels. We discussed hypertension also in part 1. In this part 2, we're going to talk about coronary artery disease, angina, and myocardial infarction. And then in the third part of this cardiovascular lecture, we're going to talk about heart failure, peripheral vascular disease, atrial fibrillation. So again, this diagram depicts progression of cardiovascular disease over time. Starts with atherosclerosis, which causes hypertension, leads to coronary artery disease, and ultimately pump failure or heart failure. So basically what happens in atherosclerosis, or basically coronary artery disease, is atherosclerosis in one or more of the coronary arteries. There's arthroma formation. So I have a picture of an arthroma there also in one of the coronary vessels. It's basically blood flow blockage in a coronary artery to part of the heart. And that can cause a myocardial infarction or ischemia of the heart muscle in a particular area because of the blood flow blockage. So risk factors, okay, for coronary artery disease. First is the waist to hip ratio. And there's a large emphasis put on the waist hip ratio as a risk factor for coronary artery disease. So it has to do with, are you either an apple or a pear-shaped body? Okay? Does the person carry more of the weight in their hips and thighs, being like a pear shape, or are they more of an apple shape, okay, or have adipose tissue in their trunk and around their visceral organs and their heart? Okay, so in a risk factor for coronary artery disease would be women having a 0.85 waist hip ratio or higher, or men having a 1 or higher waist hip ratio. Obesity or being overweight is also a very important risk factor, and I have some different BMIs listed on your slide. And then also diabetes, because there's microvascular changes that happen in the vascular system with diabetes, especially if the diabetes is not controlled. Being male or being postmenopausal is a risk factor because of testosterone. A family history of a myocardial infarction, and then also smoking. Cardiovascular disease can present in one of two ways, either asymptomatic, but with a positive stress test, or presenting as angina or an anginal equivalent event. So in an asymptomatic patient with coronary artery disease, they may just come in for like a checkup with their cardiologist. The cardiologist may say, hey, let's do a stress test. And boom, we find out that because of the stress test that caused some angina, and they're diagnosed with coronary artery disease. Sometimes coronary artery disease can present as an MI or a heart attack. Okay? Either way, if they're asymptomatic or have an MI or they present with angina, they do need to have a cardiac cath. So however they present to us, diagnosed with coronary artery disease, they need to have a cardiac catheterization. And it's done for two reasons, to see how extensive the coronary atherosclerosis is. And it also lets the cardiologist put in a stent if a stent needs to be placed in one of the coronary arteries to keep the vessels open. So remember, coronary artery disease is atherosclerosis in the coronary arteries around the heart. So if a patient presents with angina, the most important question to ask them is, what were they doing when the symptoms started? Okay, so if they present with angina, angina equivalent event, what were you doing when the symptoms started? If they were doing something like really hard, like shovel snow, or they just ran a marathon, they rested, the chest pain went away, or if they took their nitro and the chest pain went away, it probably isn't, okay, or wasn't a heart attack, okay? The patient probably has some stable angina. They still have coronary artery disease. When there's an increased oxygen demand and workload on the heart, it causes the chest pain, the angina event. But with rest and nitro, that goes away, not a heart attack. But if the patient was just resting, if we ask them what were you doing when the symptom first started, they say I was just resting, then that might be an myocardial infarction. Okay, either happened or happening. Okay, and unstable angina. Either way, okay, we need to clarify the symptoms that they're having, and then we need to have these. We need to ask them these things so that we can better manage the angina event and better determine what happened. Okay. We want to make sure also that we clarify the symptoms that the patient is having. We need to ask things like, have they had these symptoms before? What did the patient do to make it better? What other symptoms were you having? To determine if the event might be something more significant. Okay, so first and foremost question, what were you doing when the symptoms started? Okay, if they were doing a lot of exercise, which could be stable angina, or is it something more significant like unstable angina and a possible MI? If that's the case, we need to make sure that we get more information about those symptoms to determine the course of treatment. So this slide has the signs and symptoms of stable or unstable angina, and also symptoms that are most like a myocardial infarction. So for stable angina, okay, occurs with activity, okay, when there's increased workload and oxygen demand on the heart. Stable angina is relieved by rest. Unstable angina then occurs at rest or when the patient is having minimal activity. A lot of times unstable angina is relieved with nitroglycerin. But in MI, okay, it gets progressively worse. The pain gets progressively worse. If there's no care within a few minutes of having an MI, the patient could also die. And pain with an MI due to coronary artery disease occurs at rest. It is not relieved by rest or with taking nitroglycerin. So a lot of times we give nitroglycerin 3 tablets within 5 minutes of each other. It gets progressively severe, is very unrelenting, that chest pain, okay, those symptoms. With both unstable angina or an MI, the patient does need to get to the hospital, okay, to go for further testing to determine what's going on. It's common sometimes for patients to come into the ER and say, well, I've had this chest pain for, 5 days. It's a little uncomfortable. It doesn't really go away. If the patient, when we're asking them those questions and things that was on the previous slide, if they come in presenting like this, it's probably not an MI. It's something more like stable angina or something else going on. MI pain, again, gets progressively worse. It does not go away with rest or with nitroglycerin. So emergency care for angina is really to lie down and stay calm. That's the first thing we have to do. Decrease that workload of the heart, decrease that oxygen demand on the heart. Morphine can also be used because it helps kind of calm the patient. Okay, helps with their breathing, helps calm the patient down. A very rapid assessment is needed. We need to take a really good history, and then we ask questions like things on the right, okay, the 10-second survey. And these need to be done very quickly, okay? They need to have an EKG done, and the EKG is done usually within 10 minutes, okay, of the arrival to the emergency room. And it's really the most important diagnostic test for somebody that comes into the ER with chest pain. And then we use MONA. Okay, so MONA is an acronym, and we don't need to do MONA in this particular order. Okay, but it is to give nitroglycerin, okay, to relieve, possibly relieve chest pain. And again, we can give nitroglycerin 3 tabs, 5 minutes apart, to give aspirin. And it's really important with the aspirin that they chew the aspirin up and swallow it. We can give morphine and then oxygen. Okay, so that 10-second survey, as I have here on the slide. Okay, so we check or we survey the patient. This is our rapid assessment. The history of the symptoms, like those questions on the previous slide, the 10-second survey, and then vital signs. Okay, so the patient needs to have a 12-lead EKG for diagnosis within the first 10 minutes of arriving to the ER. Now, the most important thing that we look for on an EKG is this ST segment elevation. Okay, so you have the little diagram of, part of a strip, okay, and it has an arrow pointed to that ST elevation. And we do an EKG to check for, these electrical, the electrical conductivity of the heart, because dead tissue cannot conduct electricity. We can also do blood tests for cardiac enzymes. Troponin 1 is the most specific enzyme related to the cardiac. Okay, so we can check the troponin 1 and also the CKMB. And a critical rule about diagnosis of an MI is that if the troponin is elevated, they are having an MI. Sometimes the troponin is elevated, the patient is having an MI, but we might not see this ST segment elevation yet. Okay, so that's why we do both tests. Okay, so if the troponin level is elevated, it is an MI. But we also, as I said, look at the strips for the ST elevation. But here's some other tests that we might do. A cardiac cath is something that's done in radiology, and it estimates how bad the stenosis is in the coronary arteries. Okay, so these are just some diagnostic tests for coronary artery disease, not necessarily for an MI, okay, or some type of cardiac event. So with a cardiac cath, all right, they place a catheter, okay, in through the femoral artery, and that is snaked up into the coronary arteries. Right, we inject a dye, and then X-rays used to see how the blood is flowing through the heart. Okay, so the dye kind of flows through those vessels, and that mimics a blood flow. So with this, okay, this cardiac cath, we can see if there's any blockage in those coronary vessels. During the cardiac cath, the patient is already in a position that if the physician, okay, the cardiologist needs to place a cardiac stent to promote blood flow to open up that coronary artery, they're able to do so during the cardiac cath. Okay, so I have cardiac cath, the actual name of the exam there. It estimates the extent of the stenosis in the coronary arteries, and as I said, it allows the provider to put in a stent, okay, for percutaneous coronary intervention. We can also do an echocardiogram, and with an echocardiogram, we watch the movement of the heart. If part of the heart is not moving, that tells us that that particular part of the heart cannot contract and is probably dead or has died due to a cardiovascular event or an MI. So it's also called echocardiogram, often is referred to as an echo. It visualizes the motion of the myocardial wall, so contraction of the heart. It can visualize opening and closing of the valves as well. Okay, so we can watch those opening and closings of the valve, and we can diagnose valve disorders from the echo as well. The injection fraction is the biggest thing that we get from an echocardiogram. All right, we're going to talk about ejection fraction in this cardiovascular lecture as well. But an echo estimates ejection fraction, which is really an important part to see how much blood the heart is actually pumping out. Okay, so how much blood is being pumped out of the heart to get to the tissue. So here's the medical interventions that we follow when somebody comes in for a cardiovascular event related to coronary artery disease or an MI, especially a possible MI, is the MONA. And MONA has really evolved over the last few years. So we give nitroglycerin, okay, and the standard dose is on your slide. We give the full course of nitroglycerin, so 3 doses or 1 dose every 5 minutes over 15 minutes. Okay, so 1 dose every 5 minutes times 3 doses, so a total of nitroglycerin given over a 15-minute period. We give aspirin 324 milligrams, and it's very important with this that the patient chews up the aspirin and then swallows it, because this helps increase the absorption. We can also provide morphine. It can help decrease the workload of the heart because of decreasing severe pain, but also to decrease anxiety or shortness of breath. And we can give morphine, especially if the nitro does not relieve chest pain. Again, to bring the heart rate down, to decrease the oxygen demand that's put on the heart at this particular point for the patient. And the standard dose of morphine is there on the slide. So we give 2 to 4 milligrams IV as needed. We can also dose morphine every 15 minutes if we need to. Okay, so depending on the particular patient, how much anxiety, how much pain, if nitro is helping or not, we can give morphine. Oxygen can also be given. Only if the oxygen saturations are less than 92%. That's the qualifier to give oxygen. We need to do continuous pulse oximetry on these patients. So we can provide O2, again, to help get the oxygen into the bloodstream to flow to the tissues, decrease the oxygen demand of the heart. And then a beta blocker is a newer thing that we provide for an MI, and research has shown that a beta blocker preserves myocardial function, okay, even when there's myocardial cell death. If we can get the beta blocker in, we can cause more cardiac tissue, I guess, to survive, okay, and preserve, okay, that blood supply and that oxygen to the heart. Okay? So if you remember back to some of our previous lecture here, that oxygen demand is really driving the MI. So anything that we can give to reduce the oxygen demand on the heart can preserve heart function. Okay? The drug of choice for a beta blocker is metoprolol. Okay, and every patient that comes in with chest pain goes to the cath lab, okay, for diagnostic testing and then a possible stent placement. Okay, so this is what they do, okay, what the radiologist and cardiologist possibly may do in the cath lab. All right, so on the left side of the screen, you see angioplasty. All right, so basically a balloon is inserted into one of the arteries, and that squishes like those foam cells, okay, and the lipid core to the sides of the vessel. Okay, when the balloon is removed, okay, from the artery, the vessel is clear. So a stent is what's on the right side of your screen, and a stent can improve outcomes with angioplasty. Okay, so it can improve the outcomes. Because foam cells can often re-expand quickly, okay, to reclog that artery. Okay, but a stent prevents this from happening. Okay, so a stent can improve. With a stent, a patient could have improved cardiac care. And there's two types of stents that can be placed: a bare metal stent and a drug releasing stent. Okay, so a bare metal stent is just the metal that's placed in that coronary vessel to keep those foam cells from re-expanding in the vessel. Or a drug releasing stent, there's a drug that's put into the stent, usually some type of anticoagulant to prevent clotting in those vessels. All right, so before someone goes into the cath lab for angioplasty or a stent, okay, they must sign an informed consent. Okay, so they must have to know the risks and the benefits of any procedure. We also do labs, okay, on the patient. So these are, pre-procedural cardiac cath. All right, so an informed consent. We draw some labs, okay, that are listed here on your slide. We need to know what baseline the kidney function is because of the dye that's used in the cath lab. Okay, the dye that's used is notorious for decreasing kidney function. So we need to know what the baseline kidney function of the patient is. So if the patient develops renal failure, goes into renal failure, we'll know that quicker. We need to know if they have a potassium and correct any potassium issues, okay, also before going into the cath lab. We need to do clotting studies, pt-INR, because these clotting shows how long we'll need to keep pressure on the femoral site, post-cath, and also the risk of bleeding. Patients need to be NPO just in case something happens and we need to send them, to surgery, and they're also sedated for this procedure. We clip the hair, okay, around the site. We teach post-procedural care to the patient before they go into the procedure. So what's going to happen when they come out of the cardiac cath lab, but we don't want to scare them. Okay, so we always want to do any post-procedure care and teach them about what's going to happen, but we don't want to scare them. And also baseline vital signs. So this is a site that's prepped and ready for the cath lab. Okay, so you see it's a groin site. Okay, so we've clipped the hair and everything around there. The line dots, okay, that are placed is used for landmarks. Okay, where to place the catheter in the femoral artery. The site is always cleaned. Okay, and as for clipping of the hair, we always use surgical clippers. We never use any type of razors. So this is what's happening during angio, cardiac cath, okay, or angiography. Okay, when we look at the vessel, the cath is inserted through the femoral artery. It's snaked up into the heart, and dye is injected. And then we look to see how stenotic the coronary vessels are. Okay, and we look at those coronary vessels under X-ray. Okay, so you see where the cath is going into the groin area there, how it's snaked up, okay, into the heart, into the actual vessel, the catheter placed there, the dye, and how it moves, past that plaque buildup, okay, or that arthroma. All right, so coronary angiography or cardiac cath, excuse me, those words are often used interchangeably. All right, so coronary artery bypass graft, okay, or a cabbage. If there's a stent or angioplasty, okay, are not an option. If the older adult has had many MIs or has many blockages and it's very severe, then often we'll perform a coronary artery bypass graft or a cabbage. So with a cabbage, we use a vessel from another location, usually the saphenous vein from the leg, but now we've seen or using more of the internal mammary artery. And basically what's done, usually what's done is that they'll stitch the vessel, okay, this other vessel, to the aorta, and then the other end distal to the blockage, so that the blood flow is routed around the blockage of the coronary vessel. Or it almost creates a detour. These are always done in the OR under anesthesia. Usually when the patient comes out of surgery, they'll have 2 chest tubes in, one in the medial sternum and one lateral. ICU, post-op care, okay? These patients are always in, an ICU on a ventilator. We talked about the chest tubes. We have a pulmonary artery catheter that's placed, and there's continuous monitoring for a tamponade. Okay, so pulmonary artery cath, we put that in to monitor the pulmonary pressures and pulmonary waveforms. And then we monitor for tamponade because if the stitches break on the graft, they will have like blood shooting from the aorta, and that fills up the heart cavity very quickly and will cause cardiac arrest. If the patient develops tamponade, then we need to take them back to surgery. The chest is reopened, they restitch, the artery and things. So after an MI, or if the patient has long-term CAD, they should be on antihypertensive, okay, because there's probably a long-standing history of hypertension. We also provide them with dual antiplatelet therapy. So we start the patient on aspirin and something like Plavix, okay, and we provide both of these daily, okay, for the patient who is post-MI for a few months. Then after about 6 months, we may need to continue both or maybe just continue the aspirin. It's going to depend on the patient's progress and what the cardiologist wants to do. Statins and nitrates are given to the patient. And they should also have a prescription for nitro-PRN. Most of the patients after an MI will be on a beta blocker unless it's contraindicated. And the most successful beta blocker after an MI is metoprolol. Calcium channel blockers also can be given. Diltiazem and verapamil will contribute to heart failure. Okay, often so amlodipine is often the drug of choice, okay, post MI or for long-term medication therapy for coronary artery disease. After coronary artery disease or MIs, these are or long-term coronary artery disease, I should say, or after a myocardial infarction, it's really a life-changing event. Many people will wake up and take note of this, so it's really important for nurses to do a lot of teaching and coaching with these patients. Okay, right after the myocardial infarction, we're going to do a lot of monitoring. Okay, a lot of cardiovascular assessments, like the things that are listed on the slide. We want to assess how well the heart's pumping, how well the brain is perfused. Okay, so that's why we test level of consciousness, the cognitive state, but also the other things that are listed on the slide. So we do a really good cardiovascular assessment. We want to really look at risk factors also that the patient has for coronary artery disease and for a recurrent MI. And we want to promote healthy lifestyle. Since they've had one MI, they have coronary artery disease, they're really at risk for having another MI. We want to make sure that we order and the patient has an EKG once a year to monitor for any kind of significant changes that they might have. Troponin level is not something that's done regularly because the troponin level should go back to baseline after the MI, but they might have to have a troponin level done a few times after an MI, and maybe if symptoms occur again. We get a chest x-ray once in a while to see if lungs are having any kind of issues after the MI or after any cabbage. We would do an x-ray to check for chest tube placement after surgery as well. And we really want to monitor coping and address any family concerns of the patient. So we want to monitor cardiovascular assessment. We want to monitor the things that are listed here on your slide, especially right after a cardiovascular event. Okay, and then we want to, we want to monitor, we want to perform, and we want to teach. So we want to teach or we want to perform things that conserve their energy or stagger any activities that are done with the patient during the day. We want to make sure that we do all of the different referrals. We want to actively engage the patient in smoking cessation. Okay, we can help assist the patient, get a prescription for medications and for smoking cessation counseling. DASH diet is important for them to follow. Any type of emergency care, we want to go ahead and perform at any time, or we want to be able to perform any type of emergency care at any time because of the high risk of having another myocardial infarction. Patient can develop chest pain at any time, so really with severe coronary artery disease or after an MI, they're at severe risk for developing another one, so or chest pain at any time, so we want to be ready. We want to prep for any tests that the patient might have. We want to talk to them about advanced directives. Conversations about advanced directives should be done early in the disease state, not waiting until an emergency happens. And then teaching. Okay, we want to make sure that with our teaching that the patient understands that even if they have no symptoms of coronary artery disease, they can't do whatever they want. They need to do everything that they need, okay, that we teach them to do, because their risk of having another acute MI is very high if they don't follow the treatment plan. Okay, so we can lower the risk of another acute MI if they know about the disease process, they take their medications, they're doing their monitoring, exercises. Okay, so we teach the patient to monitor blood pressure and heart rate, also their endurance level. If it's unstable angina, right after an MI, or if the patient has unstable angina, we want to hold up on exercise, okay, until cardiac rehab can start. Cardiac rehab has really improved outcomes for patients. The patient should lift no more than 5 pounds for about 6 months after the surgery, or possibly, at least for a few weeks. Okay? The patient can also resume sexual intercourse as long as they're symptom free. And what we usually tell patients is if they can climb stairs without symptoms, then they are free to, have intercourse, and they don't have to worry about an MI event at that point.